Good afternoon, ladies and gentlemen. My name is Geoff Meade. I'm pleased to be back here. I was involved in a conference here in this very same room last year on these issues, and it's nice to be with you again. And I'll keep talking while the panel assembles itself. Oh, thank you. I've even got a badge. There we are. I'm an independent broadcast media professional, and I'm very impressed about that. But I'll just tell you who's coming on the stage. You've got details of the panelists today. Karin Kadenbach, MEP. She's vice chair of the European Parliament's delegation to Japan, but I don't think we're going to be talking about that today. I think her role on the ENVI committee, particularly the public health side of that, is more important today. Marios Kouloumas is where's Marios? Hello, sir. I remember last time. Nice to see you again. Who is the EULAR's vice president representing PARE. You know him well. Professor Anthony Redmond. Good afternoon, sir. Who is here? I think I saw you last year. I can't remember. Indeed. Sitting opposite you last year. Very good to see you again. Professor Lasse Lehtonen. Hello. Good afternoon, sir. Very nice to have you on here too. And it says I'm on here too, so that's me. I think we've got about an hour, ladies and gentlemen. This is really your time for questions. You've just had one shot at that. I'd like to go straight on and raise something from the wealth of material about the state of this directive since 2011. What drew my attention is in the Commission report to the European Parliament and the Council, and I'm not trying to be sensationalist, but it really quite shocked me what it said. In that report, which is, as I say, before the Council and the Parliament right now, first of all, it criticises many member states for failing to fully implement this directive even now. And it says this: there are a considerable number of member states where the obstacles placed in the way of patients by health systems are significant, and which in some cases appear to be the result of intentional political choices. Now, as a working journalist for many years, that's something we sniff at and think there's controversy and conspiracy going on there, and I'll be interested to hear what Karin has to say about that. But I'd like to raise that point with the panel, because it did seem to me rather odd, talking about deliberate political obstacles being placed in the way of this directive working. So that's the one point. The other point I picked up, as you did, the lack of communication strikes me as very odd. Lack of cooperation has been remarked on in many of the reports. Are the national contact points to blame for that? I don't know. I will not say any more. That I just, by way of allowing all the panelists to introduce themselves, I'd like them to try to address the points I've made, and indeed take up anything they want to from the workshop reports. And we'll just go, just for convenience, we'll start closest to me, Roberto, and go across the panel. Roberto.
Do you want just introduction or some initial comments?
Just initial comments would be good, on the basis of what we've heard.
Okay. Well, I mean, I think this directive actually is a very important one. Well, let me say that from a person who strongly believes in Europe, so not in the with the head of the WHO. I mean, I think this is really a very big step forward in the direction of one continent and one Europe. I mean, so this is a very important thing. And the resistance also in the application of this directive, which we have witnessed in the documents which have been circulated some time ago and discussed also on the informal meeting of ministers a few weeks ago, is actually the signal of some, I mean, political difficulties in a number of countries to create this environment in which this type of directive is fully implemented. As you know, in WHO, we are particularly concerned about inequalities, and we are particularly concerned about inequalities in health system access, of course, in the health conditions. And we believe that this directive, although addressing only part of the problem, I mean, could facilitate the solution, I wouldn't say the solution, but partly address the problems of inequalities in the access to health systems in some parts of Europe, and particularly make available services which are not available in in other areas. For instance, this is very important for rare diseases. There are European networks for rare diseases which are being built also, which I think is very significant to ensure that countries such as Malta or Slovenia or other small countries might have the possibility to send their patients and to refer their patients to different countries in the continent. Now, I think one of the main problems in the implementation of this directive is also due to the financial difficulties which many health systems are facing these days. I mean, many of the health systems in Europe are actually have cut heavily their budgets. They have problems in securing their own facilities to the citizens of their own countries, and this can create difficulties in actually opening up to additional customers, if you wish, in this particular domain. So I think this is another issue that we should remember. And I believe that these issues also links somehow, although indirectly, with the European semester cycle, with all the budgetary concerns which are reflected in the European semester. And as you know, I mean, there's been a request or an attempt of some member states to facilitate the involvement of the health sector into the European semester process, which actually is not agreed by a number of other member states. So there is a problem here that we need to see, we need to face. I mean, the comparison to the effectiveness of different, health systems, the capacity to compare results and efficiency. And I think in some cases, the difficulties in the implementation of this directive is also the consequence of some sort of of reluctance to introduce another dimension in this business, which is already complicated by itself. So these are just a set of initial thoughts that I made by looking at the slides a moment ago and on the basis of your considerations.
Thank you very much, Roberto. Karin, what strikes you as most prominent in this discussion?
Well, first of all, I'm sorry, I only heard the last part, Professor Wolf, from the fourth workshop. But I think I can go on what Roberto just said. It's mainly a question of finances, and I think that most of the member states actually still do think that health and organization of health is just a matter of member states. They have not really realized it with not only with the Treaty of Lisbon, health is also a European matter. And I'm pretty sure that if we haven't had the court decision that we have to implement something like the cross-border healthcare, we would not have it today, because that's something most of the member states do not think it's necessary. They do believe that they still can do it on their own territory. So that's probably why, and another thing that was very important for me, because I'm really trying to put more focus on health literacy. Most of the European patients actually do not know enough about their rights, the possibilities. They do not know their way in the health systems. So I think it's first of all, it's a question of access to diagnosis. That's something people very often do not know how to get it. They don't get it in time. And the other point is access to treatment. So that, as you mentioned before, I'm together with my colleague Andrei Kovacev. We have this interest group now for better access to health, because we do think that a lot of the inequalities in Europe are due to this different access and to health illiteracy, actually, to say it correct. So, and another question is the very different health insurance systems we do have in Europe. Because some people actually are afraid to see a doctor, because they are afraid that they will get a diagnosis, and that would mean costs for treatment, costs for medicines. So that's also a question, what can I expect from my health insurance system to get reimbursed? And that's probably also a question why it's very important that we have cross-border health care, that we have the possibility. But I'm as long as the people are still afraid that they cannot afford it because the reimbursement is only the money they would get for that is paid for the treatment in their member state. So as the reimbursement is very different in the different member states, sometimes it's quite a lot of money that's still to be paid if you have health services in another member state. So I still think there is a lot to be done.
Thank you very much. Anthony Redmond.
Thank you. And I would agree that it's clearly an issue of finances. I think that there will be some political resistance because of the cost of implementing this fully. But I think also there's a case here that they slightly underestimated the scale of the undertaking. When you look at the potential for cross-border movement to follow healthcare, historically we often use as examples the smaller or less developed nations and how people will move from those to the larger nations. But I think we've also a situation here where there are large equities even amongst the more developed nations within the European Union. And I think we've heard already, this relates to rare conditions particularly. I think we've got, in the context of highly specialised care, the potential for really large numbers of people to be affected by this. So I think there's a resistance amongst some governments to implement fully, because if you have potentially thousands, tens of thousands of people wanting to move because they can see that over the border they have access to a therapy which is denied them in their own country, I don't know yet that the systems are mature enough for us to be able to deal with this within the Cross-Border Healthcare Directive.
Okay, thank you very much. Lasse.
Well, when the panel goes on, of course, you start to repeat the issues. I think the basic problem, of course, with the member state, why they don't implement it, that the systems are national and the cross-border care is not fitting very well to the national schemes. I think one of the issues is that nobody is really showing the benefits for the system. So previous speakers were stating that cross-border care is creating new cost. Okay, that's true, but only partly, because if the cross-border care is part of the planning, you could actually also spare some cost in the healthcare system, because you are able to build better units and better systems, and you don't have to repeat the same the units everywhere. So that type of common planning is missing in Europe, and I think that's part of the solution, that if we want to develop healthcare in Europe, that has to be there. I fully also agree that one of the issues are the health inequalities. If the cross-border is only for the educated and those who can afford to travel, then we have created something that is probably not very useful for the European healthcare system. I strongly support the idea that the European reference network should have some type of common funding that could enable also patients from the countries there are less resources for these treatments to have access to good quality healthcare.
Thank you very much. Marios.
Yes, it seems that unfortunately everything is related to financial, and there is a financial crisis, of course. So, but don't forget that early diagnosis and timely access to treatment and provide this kind of holistic approach of the medical systems, and then reduce the impact and the burden of the disease. So this is one important thing that we should have in mind. So the directive is very important, of course, and this is a great opportunity for patients to seek the best services, medical services in their country or in other country in the EU. It's obvious that the member states, they have hesitations in order to implement that directive. This is, I think, very obvious, because in many countries they have not announced even the contact points. So we are the leaders of the patients' organizations, and we don't know all about this directive. So what about the patients in the country? So this is very obvious that they don't want to implement that. Of course, it's a very complicated directive, and we need first also to be aware of all the things about this directive. It's very important for the patient organizations to collaborate with the national contact points in order to implement that. And this is, of course, the one side of the coin. The other one is that, and this should also should be our aim, is to improve and to implement standards of care in all the EU countries. That maybe at the end of the day, we don't need to go in other country to seek for a better care. So if we have the same standards of care in all the countries of the EU, so that people stay at their home and they can receive this high quality of care.
Thank you very much for all those opening comments. Okay, we've set it out there. Does anyone have any questions at this point in particular to anyone about anything? Okay, well, the thing that I want to pick up on, because it's the common theme and it surprises me a lot, doesn't surprise me about the financing, doesn't surprise me about trying to marry national systems, national health service systems, to a Europe cross-border system, and that problem will never go away, of course, because the two don't quite marry. What I find staggering is to hear, and of course I believe it, that there's a big information gap. The one thing that's cheap and easy to access in this world is information. Of course, all the information for patients is on the Commission website. Most normal people wouldn't think about looking at a European Commission website. I think that's fair to say. But it does strike me that you've got these national contact points. There's a reference in the Commission report suggesting that there ought to be an exchange of best practice. Well, I mean, yeah, of course there should, but I can't believe it's not automatically happening. And I certainly find it odd that our workshop teams sort of indicated in varying degrees that this was a big problem, the information. So what's the biggest problem? The lack of information for patients who want to access these cross-border services, or when they've got the information and they access the services, the problem that the treatments don't necessarily marry up across borders, or the financing is wrong. I don't know who would want to take up that, but just this point of information, how can the information gap be so large 4 years into a directive? Karin, you're in the information game in a sense.
I do think you're already 2 steps ahead. It's not only the national information points people do not know enough. Actually, they do not know where to get diagnosis, where to get treatment, where to go to. They do not know that they cannot read their symptoms. So I think it starts on a far lower level. So we have to have better education, health education in school, on the working place. I think things like doctors on the working place where you can go with your symptoms would be the first thing. I think the National Information Fund, I mean, that's that's a vision actually.
Okay, just to add to what I said, and the other point, because who would you blame for, at the current situation, we are in the situation we're in, who is to blame right now for the lack of information, if you can pin the blame? Anthony?
I was going to come back to Karen's point, which is to say, if we improve health literacy, does that actually create more of a demand on the system, and is the system prepared? Yes. So in terms of, it's a parallel question to the question you're asking about the cross-border.
That's a very fine question. Sorry, I correct what I've said. Don't tell anyone anything. The system can't stand the strain. Gentleman at the back has a question.
Peter Carter from the UK. I'd just like to give a perspective, and I can only really speak from the UK. The reason why it's not happening in the UK is that it's politically unacceptable. Politicians, there's a huge debate about whether the UK should stay in Europe, and there's a lot of scaremongering headlines about all of these infidels from Europe going to come across the channel and raid our healthcare system. The healthcare system's already under pressure, so it's politically unacceptable for the government of the day to do what ethically they should do, and that is promote this. Because with due respect to our members of the European Parliament, and I'm a great fan of Europe, it's one thing passing a piece of legislation in Brussels, it's another thing operationalising it in countries. And what it needs is for individual governments, member states, to then be prepared to promote it. And right now in the UK, both the current government and the opposition are very unlikely to do that.
Thank you very much for that point, which I'm sure someone will take up in a minute. Any other points or questions at the moment?
If I may comment,
yes,
I think actually the issue is also in the primary healthcare, because I would think that it is pretty impossible to get all the people in Europe knowing all the possible diseases and the treatment options. So basically you have to educate the primary healthcare staff and they should pass the information to patients when they meet them.
Thank you very much for that. Point that occurs to me from what you said is that, I mean, if I was arguing the case, I'd say, well, okay, Britain has a referendum and a lot of difficulties with Europe right now, but they signed up for this. There is some imperative upon a member state which signed up to a thing to fully implement, of course. Promotion is another thing. I mean, no member state signs up, say, I promise I will do wonderful public relations. I mean, that you would just automatically think that would happen. But so there is that thing, but that is an interesting point, that nothing's really simple right now involving the UK in Europe. Yes, of course.
No, I think that one of the does it work? Yeah. I think that one of the issues that we have to address, and it's been mentioned, but perhaps it needs to be developed a little bit more. It's not only the health literacy to the people, I mean to the citizens, but also the literacy of this directive to the medical professionals, which is actually quite missing. It's not only primary healthcare, which was already mentioned, but also the more advanced care. I mean, hospitals, secondary, tertiary hospitals, and even within the ministerial authorities, this information are not so much, available. And of course, this links also to the health literacy part for that part of the concept of health literacy, which means being able to navigate into the health system. Which is actually, it's quite a challenging issue, because at the moment it's very complex to have access to this, to the provision of this directive. It's very complex per se. So I think all of those aspects need to be actioned upon. And I think the role of the patients' organizations is very important. I mean, to push the authorities, but also the medical professionals, I mean, to get information about that, to be proactive in these type of things. Of course, I mean, you have to recognize in some cases that you cannot deal with the problem. And I'm a doctor by training, so this might not be so nice for a doctor to say. But I mean, it's something that you have to admit, in an age in which there is a very highly specialized medicine with very complex diagnostic and therapeutic, possibilities. I think this is something that we need to, transmit and convey also to the medical professionals.
Thank you very much. Karin, can I just ask you, this report to the Parliament and Council, where is it? What's happening to it right now? And does the Parliament report back on it, or what's the next stage?
Actually, we should report back on it, but it's not on the agenda yet.
This is part of the Commission doing less and doing better, is it? It's passing down through the Parliament. Okay, but the Parliament will, does it have to approve that report? It has to approve the Commission's report. Is that how it works, or is it just an advisory document?
We do not, we can, we comment on it. We do not have to approve it, comment on it.
Okay, so it's not worth these people here paying you lots of money to write in the conclusions the things that they want here today. It's not
better to go to the Commission.
Better to go to the Commission. Okay. It's not often you hear a parliamentarian say that. Yes, Maris, please.
Yes, I would like to also to add to what you have commented before, that I think that the national government, the member states, they should take more decisive steps forward in order to implement the directive, and it seems that they are not willing to do that. And there is this thinking that the national contact points, they are the gatekeeper instead of facilitate the people to access or to implement the directive. And so I think that we should concentrate our efforts and encouraging the national governments in order to implement that. So it's the member states that they should take this forward.
Okay, thank you for that. Someone, one of the workshop report backs mentioned in passing migration. It's been mentioned once today. This may be a silly question, but I'll ask it. This great migration flow we're seeing now, just on this narrow issue of healthcare, does it have long-term implications? If we've got hundreds of thousands or more people who do ultimately, for whatever reason, settle in our member states, presumably a year or two down the line, we begin to see the knock-on effect on healthcare generally and cross-border healthcare, or am I mixing up two big separate global problems?
Well, no, we have been involved as WHO quite substantially in the recent movement of people. I mean, from the affected areas in Northern Africa and Sub-Saharan Africa and Europe. So one of the issues that we have been facing is actually the problem of access to of healthcare from these large population groups. I think this is actually, there is some similarities on this issue, I think. I mean, you are not wrong in making this link. And it's clear that in the future, particularly for refugees, I mean, then there are, economic migrants, which in some cases are illegal. So then there's a big issue there. I mean, whether an illegal migrant can have access to health system, to health services. But I think this will pose for sure an additional burden. Although, I mean, and this is difficult to quantify at the moment, also in terms of typology, because of the diseases and the type of burden that will pose on the health systems. For instance, I should give you an example. If children migrate from Syria or from one of those countries, in Syria, for instance, there was a very high vaccination coverage, but they don't have documents on these issues. And you cannot, it's more expensive to analyze the blood of these children to check whether they have antibodies then make another vaccination. So they have to do again all the vaccinations. So this will pose an additional burden on systems which are in some countries overstretched already. So that's the main issue. And of course, in this condition, opening up to cross-border healthcare, patients from other European countries is posing an additional dimension, although in quantitative terms, this is much lower and is not a big deal.
Thank you very much. Oh, yes, please, Karin. Yeah.
Yes, I do think it really depends on how we're going to handle the situation, because if those migrants will not be part of the system in the future so that they can work, contribute financially to the system, then it will be a big problem. Because if they're just waiting to get treated and they're not paying themselves into the system, it will be a burden. But it can be a big chance for Europe too, on the other hand, because with them, we do have another workforce. We have young people, especially for the healthcare system. We do, for the caring part, especially, we do need people. And the other thing is, if we look at our demographic future in Europe, we do need young people, because we know that the most expensive are people in their last, let's say, third of their lifetime. So if there's nobody on the other side, young people working, paying into the system, we won't have the money for care and for medicine and everything for the elderly Europeans. So I think it can be a chance if we take it as a chance and not just as a burden.
Thanks for that. Karin, when you say elderly, the personal question, what age? What age would you put on being elderly?
Actually, people who are not actively working and paying into the system. So
Okay, no, I'm just trying to assess where I am on the scale, because I'm feeling very old, really. Questions, ladies and gentlemen? No? You're all very happy? Good. Okay, then I will... oh, yes, please. The microphone is rushing towards you. Oh, actually, you don't need to rush, don't worry.
Thank you, Elena Nikifor. I'm a rheumatology fellow in the UK and also belong to the emerging EULAR network. I have a thought to share and also a question. From listening to lots of patients here today representing different countries and also to Marius Kouloumas' talk, I wonder whether maybe healthcare across borders should be restricted to people under exceptional circumstances, partly to also encourage individual countries to up their game in terms of the healthcare they provide. I've heard a lot of people say today that a reason for accessing healthcare across the border is waiting lists, costs. Are these real reasons for which we should be encouraging such an initiative? Just a thought.
If I may say, I think that's a very fine question. Because, just to follow up on that point before I let loose with the panel, I read somewhere in the various reports on this that it was the opening up of cross-border access for patients which would encourage competition amongst national healthcare systems. But I rather favour your point that it would be the other way around. If yes, that's who would like to take up that point? Completely radical new approach to healthcare in Europe.
Yeah, I think actually the competition issue is relevant for common diseases as well, because this is really putting the patients first and not the system first. I think we need both. We need both the reference type of networks, centers of excellence that are keeping up the quality and start developing the whole medical field in a way, but then the real life issues has to be taken care as well, because the quality of the healthcare is done with the waiting lists and the patient satisfaction and that type of thing, and it's good that there is some pressure as well.
But you could argue that as healthcare services are totally national, without any EU competence directly, you could, interesting point, you shouldn't just be able to move across a border to save €150 on your treatment, or just because you have to wait 3 weeks in one country and only 2 days in another. I mean, it sounds radical, but it actually seems to make sense, because these are national services. We can't suddenly say, oh, I can buy no, I was going to say a VW, let's forget that. You can buy a Mercedes in my neighbouring country for £10,000 less, and you can go across border.
Because the services are for the patients and not for themselves. So you put the patient first, please.
Okay. Anyone else want to pursue this radical new approach to healthcare treatment from a lady who's about to be appointed Director General of a new DG on the subject? Anyone? No. Marios,
Yes,
as you had a name check, you should take up the point, yeah.
Yeah, so I think that is very good, of course, to have the patient in the center of the care, and collaborating all the national systems together is better, and to provide better quality. But also the centers of excellence is a good idea, because we cannot have in every country specialized centers for specific diseases. So it could be a nice idea to have specialized centers and excellences in different countries, and that the patients can receive this optimal care.
Thank you. Anyone else on that point? Yes, please.
I'm going to come in and take it a step further, which maybe there are sort of commercial providers out there who might see this as a free market opportunity. I mean, so far we're talking about it being an imposition on health systems, and it might be that there are people who see a way of making a fortune from taking the pressure off other healthcare systems.
Yeah. No, I think this is a very important point, because I mean, if you have in your own country a number of centers of excellence on several diseases, also the image, the performance, and the satisfaction also of the people employed there, and in general the image of the country itself can be improved by the presence of these centers of excellence. I mean, when you look at the statistics of satisfaction, the people's satisfaction for their home health systems, there are a number of cultural dimensions here. I mean, some countries tend to be over positive, and some countries tend to be, including my own, tend to be over negative. But I think there are some. When you look at the life expectancy or the survival from cancer patients, and there is a large difference in Europe on these issues. And you can see that in the future we have countries in which this data, I mean the good data in these variables, go together with the opening to the center of excellence in this particular area. I think this will give a lot of prestige also to the country. And this, health is central to the life of people, and also central to the effectiveness of government. We advocate for a whole of government approach to health, because we believe that health and well-being should actually be the indicator of good governance. And this could be also one dimension that would be, improving the image and the results of good governance.
Thank you very much. No, still no questions. I just want to move for a moment to the e-health thing, because workshop 2, the report we had back, suggested that in as much as technology is moving apace and helps an awful lot of legislative areas as it comes on stream, in this case we heard that benefit, the IT benefit if you like, is going to helping the bureaucratic processes of the medical profession, of hospitals, that's as I understood it, and not so much helping patients in terms of their understanding and accessibility to services. Anyone have any views on that point? I mean, it seems a strange imbalance that we've got, as soon as these new IT services come on stream, oh yes, it helps us coordinate accounts as do our accounts in the hospitals. Doesn't seem to benefit the patients, we were told.
I think
Yeah?
Yep, Marius,
Okay.
yes.
Thank you. So I think that e-health is very important for patients, because the first thing that I come in my mind is that there are big countries, and the rheumatologists, for example, they are mostly in the cities. So there are people living in the rural areas, and they don't have this access to the rheumatologist. So it would be nice to have the consultation, or if they have something urgent, to speak with the doctor. So e-health could be very good for these reasons, to have this communication with your doctor in every time you like, and also improve the access to the rheumatologist, or to the specialized nurse, or to the centers. So this is one of the benefits of implementing e-health. But also there are also many other things that can benefit the patient from e-health. For example, having the appointments from internet. This is also something that is very good. Instead of have a telephone number calling and ask for the appointment, or to have access to your records, to your medical records, or to the examinations. This also benefits patients.
And not really difficult to achieve, in theory. I mean, just needs a willingness to implement these systems.
that's the problem, isn't it?
It is. Sorry, then you.
I think I'm pretty evidence-based in this, and you should then look who is actually accessing the services. What we see very often is that you have pretty healthy, educated people that are using these services, and those who actually have poor health literacy are out of the services. You are actually creating, again, new inequalities in health. So I'm not quite sure that the easy access is always the solution. You have to really profile the groups and try to put your priorities who to help.
Thank you for that. Anthony, did you want to say something?
I think that we're taking a very narrow view on what constitutes e-health as well. So from a personal perspective, we have e-health solutions potentially available for a number of clinical scenarios, post-operative monitoring, range of other things. But all of the e-health potential solutions, I think, suffer from the same set of problems, which is there's a need for technological readiness, if you like, which inherently doesn't exist, otherwise someone would already be doing it. So when we come up with a good idea, to scale it up to a national level is a very long-winded, complicated and expensive thing to do. Nimble commercial companies can react to a small market, but it's much more difficult to do something on a national level. And there's commercial competition. So when you're talking about e-health, we're in an area where the sands are always shifting. That as soon as you've got a technology bedded in, your latest Apple or Android or whatever apps, something else has come onto the market and superseded the whole initiative. So I think e-health is actually on a very unstable footing when we look at it from a national scalability perspective.
Thank you.
At
Yes.
one point, I think that this, e-health as well as other, very innovative technologies are quite important in the future. Sometimes we don't see the potentials of these technologies, or sometimes we don't see, sometimes we overestimate the potential of these technologies. And I think this is an important point to consider. But I think the main issue for us as WHO has always been the concern about what was mentioned already by one of the colleagues, the possibility that these type of instruments actually increase inequalities rather than decreasing them because of the lack of health literacy. So everything is connected here. So we really have a basic problem, which is health literacy on one side and ensuring the capacity of people to interact with the health systems at different levels in a proper way. Of course, this will never be solved 100%, but certainly we can reach a situation which is better than now in terms of capacity of the people. So our concern is inequalities, and also to try to be a little bit realistic on these new instruments. Sometimes it seems to be a panacea. I mean, they solve all the problems. I mean, you have everything on the internet, fine, and everything is solved. Things have, which is not the case. I mean, technologies are sometimes help, sometimes even complicate the situation. I mean, if you think about the genetic tests, which are now easily available, people can go in some cases to have, their mapping of the genome with no implications for their own future health, except the worries that emerge from the fact that you found a number of things which are not good. And I'll give you a personal example. I did, it's not a genetic, it's actually an assessment of the chemicals in your body. And I participated to a campaign of WWF a few years ago, and they tested my blood, and they found everything. They found insecticides and PCBs and chemicals of any kind. Yeah, I'm still alive. And I asked the people, said, what can I do then? I mean, I knew that I couldn't do anything, but I asked, said, well, you should be careful. Careful of what? I'm like this, I'm born in the 50s, therefore DDT is everywhere in my body. And, for people who are here born later, maybe the situation is different and better. But so then we have to be careful. And then just to say, new technologies have a lot of potentials. We have to exploit the potentials, but not to create inappropriate expectations.
Karen, have you got some
If I may comment to
secrets?
that.
Oh, sorry, Maris, just after you, Karen, and then you.
Yeah,
Okay?
No, before you ask who are the elderly, okay, we are. So we are not the digital natives. I think that's the difference. So that's one thing. I think the next generation, that will be a lot easier for them to deal with e-health. But as said before, I think one of the big problems is that it might make the gap between those who understand and those who have not the possibility to work with e-health, to get to a smartphone, to use all these applications. So I think the vulnerable groups of low income, low education, they will not be the ones who really profit from e-health on their side. So I think we do have to have innovative treatments also for surveillance, for monitoring, for whatever that should be. But still, I think a human being is a human being, and it's not just a machine that can be on some monitor. And even there, it's sometimes people who work with the machines. So I think we should really take care that the people have the possibility for personal contact, for personal exchange, so that there can be a holistic approach to whatever they need. So it's not only the e-health. I think it's additional, yes, necessary, yes, but not instead of.
Okay, Maris.
I just wanted to repeat what Professor Carmona said. The e-health is not the objective. It's the need of patients, the objectives. So the e-health is a tool to address these needs.
Thank you very much. Oh, Lasse, did you just quickly then?
Yeah, I would actually come back to the cross-border care issues, and I think their e-health issues are related really to the access to the data, so that the treatment decisions are done appropriately when the patient is crossing borders, and also that the continuity of the care is secured. So you have to really make the systems work together and the data compatible, so that you can move also the data when the patient is moving.
Okay, thank you for that. Could we have a microphone for your president, please?
I would just like to make a few remarks with regard to the electronic health record, since I'm a daily victim of them. Because so in the let's say just a couple of weeks ago, I went to my desk in the morning, and there was a pile of results from the lab. I just looked at them, made a note, and then they were entered into the paper records, and that was it. Nowadays, when I come in, I have to open up my computer, a million passwords and usernames later. I have access to a sort of a basket which I can have a look at. I have to print it out. I have to sign it. I have to send it away. And so this is a real burden nowadays. And so what we heard in the workshop was that sometimes these electronic health records, and they're not for the doctors, the health professionals, and the patients. They're more for the administrators. And if you look into the examples of our American colleagues, there was really, if you want to have a look at this, how difficult this is, there was a very nice report by Simon Heathcock in the Rheumatologist. It is called actually Barking at the Moon. So it's inevitable that we have it, but all the difficulties with the electronic health records. I will just give you one example. I was over in the United States, and at that time, you may remember there was an Ebola victim, an American doctor having traveled to Liberia, coming back to a Houston hospital with fever and diarrhea. So everyone would say, well, I mean, there must be, at least you should consider Ebola, but it was not considered. It took, I think he visited many, I think hundreds or 200 people before it was eventually recognized. And I told my American colleagues, why didn't you recognize that this might be Ebola? And they said, well, you know, with all these electronic health records, it takes you an hour until you have entered all the data and all the other things. And it just went under. No one recognized it, that this colleague had been to Liberia. So therefore, the main message was actually missed. And so we have to be very careful, and so that also these electronic health records speak with each other, which is not the case in the United States currently, because they all want to make money, and so therefore it will not be the final. It is. I realize that it will be inevitable. I have to realize that, but it needs to be made user friendly, because otherwise we will devote all of our precious time to the computer and no longer to the patient.
A very, very timely warning there, ladies and gentlemen, of the folly of high-tech equipment. Some of us on the panel, I think, agree with you. Yes, another exclusive suggestion.
Just a very quick remark, if I may. I just agree entirely with what has been said already and by Dr. Bertollini and Ms. Kadenbach. I think, and just to give the example, I don't know if you know the example of Cambridge in the UK, where I trained there, and it was a fantastic system. I worked as a fellow as well. Then spent a little bit of time in the US, tried the EPIC system, which works fantastically well in the US. Then came back to Addenbrooke's, and they had implemented EPIC, and now this trust is struggling, and it's in the red alert, and it's failing partly because of this new electronic system. So I think what you said earlier about being very careful about what and how we use it, and whether it's applicable and generalizable to many systems is an important point.
Thank you very much. Did you mean it didn't work because the technical standards were not compatible of the technology? Yeah.
Running a system that was not, in the US it's based a lot on insurance cover. Thank you. It was partly technical and partly sort of unfamiliarity with using the system, and the fact that the basis of EPIC was based on a completely different sort of principle, which doesn't apply to the UK. Insurance-based system.
Yeah, a lot of things in Europe don't apply to the UK, but is there concern? I mean, could I suggest that maybe it's not worth talking about how to improve the application of the directive when there are still 4 member states which haven't even transposed its contents into national law? I'm not sure. I've been here a long time, but I'm not sure if that's normal. 5 years after a directive is supposed to have been transposed, is it reasonable that a handful of countries have still not even done that, never mind enacting the detail, just haven't even transposed it? That's got to be a concern, hasn't it? I blame the European Parliament. Karin?
No, it's the Commission. No, actually the European Parliament is just in the process of making legislation, but to control it, it's the member states, and on top of it, it's the Commission. So it's well, I'm sorry, I'm not the one to blame.
Okay, Marius looks like he wants to say something.
Yeah, this is not very good, of course, because after all this year, and there are member states that they didn't implement something that is mandatory to implement and transfer it to the national law. So this should not be acceptable from the Parliament, from the Commission, but also from the citizens, from the people living in the country. So the patient organization, maybe they should have something to do there.
Thank you very much. Oh, yes, go.
May I add something? Because it's not just only a problem of this directive. I think it's a general European problem we have right now. We are losing credibility, because if we do have a lot of legislation that's already should be implemented, and the member states act as if it has nothing to do with them, and the Commission, is not really enforcing the implementation, not really control. So people cannot really rely on European legislation. So why should I go and vote for the Parliament? Why should I engage in European agenda if that's the outcome. And so I really do think it's not only this question, it's in every kind of legislation. If we decide on it, and it's not only the parliament, it's also the member states on the other side, because without the council we would not have legislation. So the member states have committed that they want that, and that they want to have this kind of legislation, that they have committed to implement it, to control it. So I think that's something we really, as citizens, always have to ask from our governments, to say, okay, you have said yes to this kind of legislation. Why are you still not implementing it? Why is it not working properly? And I think that should we ask ahead of all elections on community level, because it's also a question of how communities handle European and then national legislation. I think that's something we as society, civil society, as a patient group, as doctors, as nurses, really can ask for.
If I'm also to say that this also delayed the implementation of the directive, because there is a message to the other states, member states, that it's not something that you have to hurry up, because there are states that they didn't transfer this to the national law. So it is a message not to implement in the directive.
Thank you. We're coming to the last few minutes, so if you've got questions, now is the time. Gentleman there, and then lady over there. Oh, was there someone else? Yes, okay.
Geoff from Personalised Europe. As I hear it, it's not just a question of problem for the RMDs, or for it's a problem for all the conditions that this cross-border directive is not implemented correctly. So wouldn't it be a nice opportunity to go work together with all the patients' organizations, and to also the healthcare professional organizations, because you need them as well, to work together? Because if you count them all, I think you have in Europe over 300 million voters. So I think that would count for something.
Thank you for that. I'll take the question from the lady there.
Yeah, this is Kirsten from Lupus Europe. It was actually the exact same thing I was thinking. Because, you know, this is very simple. Cross-border healthcare, yeah, we agree with the focus. This is kind of what we would like. We can see the purpose, we can see the benefit for everybody, both us and for the patients, I'm a patient, and the healthcare professionals altogether. So the main thing to do is actually the two key stakeholders in this, besides hospital administrations and politicians, are us. So we have to work together to make this happen.
Thank you for that. And then I'll take the lady here who's got a question. Just, you put your hand up. So there we are.
Yes, my name is Susan Terkelsen. I'm from Denmark. I'm a nurse, and I am in the Danish Interdisciplinary Rheumatology Forum. It's on the EULAR. We have talked about the patients, and we have talked about the healthcare system, but the issue for me is also the medical industry, who have they set the price for the medical treatment, and it's a difference from country to country. For example, if you take the biological treatments, it costs around 100,000 in Denmark per person for your year, and we've seen Danish kroners, yes, yes. Yeah, the Danish kroners. But we go to Sweden, it costs the half. And I think the EU have to look at that side also.
Thank you very much. As I say, the closing session, we're going to hand back to the President shortly for the closing session. So I'd like to invite the panelists to take up the points they've just heard, and maybe draw the threads together of this meeting. We can't say, okay, here's a piece of legislation which will make everything better. It sounds to me more like it's political will that's needed, not changes in the directive particularly. But if you'd like, from your own perspectives, what's the one thing, if we could leave this room now and do it, which would advance this directive in the way of prioritizing the patients. I don't have any views on the running order here, so if anyone's got initial thoughts. Maros, you're smiling widely at me. Can we start with you?
Okay.
Please take up the points you've heard and just sum up.
So what I would take with me today after the discussion is that we should work all together, patients, health professionals, and politicians, in order to implement that effective, the directive.
Thank you. That's very clear. Should we go in order across the table, Lasse?
Yeah. As I said previously, I think key players are really both patients and the professionals, and the professionals should be educated how the system works, and I think the patient organizations should push the educational system that this type of issues would be included in the curricula, in the medical schools, in the nursing schools, and so on. That would be good. And I picked the topic of the prices of the medicines. We see more and more really high pricing of the new drugs, and when we are discussing to access to healthcare, I think we have to take very seriously how things are developing here. Unfortunately, the patent protection has not been very productive. We see less new drugs coming on the market, and the patents run long, and the prices keep high longer. So I think this should be looked and thought what would be the best way to promote affordable medicines for the needing patients.
Thank you very much for that. Anthony Redmond.
Yep. For me, the cross-border directive should just be a stopgap. We shouldn't need a cross-border directive if there are adequate standards that apply universally across the European Union. And I think it's a necessary and possibly medium-term stopgap, but I think we should be working much harder towards long-term reducing unwarranted variation in care rather than allowing people to migrate to level out the peaks and troughs.
Thank you. And now over to the European Parliament. Karin, what are you going to do?
Well, actually, just I do think that the cross-border healthcare is actually a chance where the member states really have to explain why they do not offer certain services, why there are waiting lists like that. So it's some kind of shame and blame, let me call it. I think it's a possibility we should use. Yes, what I can underline is we have to work together. It's all the stakeholders, and I think we really do have to put more pressure on the member states right now. They have to act. And about the pricing of medicines is very high on the agenda right now. But it's actually it's a question. It's not a decision that we can have in Parliament. It's actually a question of internal market. But we do have quite a few chances to put more pressure on the pharmaceutical industry to develop new medicines, new treatments, and we have to put the pressure on the pricing because they want the expenditures they have for research and development on the one hand. I do understand that point, but on the other hand, it must be accessible, and that's the question. That's also a question of our reimbursement systems, because if a treatment costs so much that it really endangers the rest of the healthcare systems in a member state, that can't be the solution either.
Thank you very much. And the last word goes to Roberto, and we wish you well with your continuing treatment.
Okay, I just would like to say that I think the full implementation of this directive would actually mean to the European citizen very much, and saying what the EU as such can do for you, basically. How you can have access to something you would not have access to if you were not in this common system, particularly for rare diseases. I stress it again, because, you know, it's true that we should guarantee equal services in all countries, but it's true that there are some problems which cannot be faced by a single country because there are too few cases that you cannot deal with. And if you add all these cases together, it's not a trivial number. So this means that this would mean something that we should be able to sell, in quotes, as one of the added value of being in the European Union, which is nowadays so much criticized. And I think we should try to reverse this criticism. And also another dimension that I want to emphasize is this dimension of the cost of treatment. Some countries are moving towards joint procurement for some drugs. and some treatments. And I mean, I think having a fully functioning cross-border care directive would actually facilitate this mechanism. Think about hepatitis C. The price is not the same in all the countries in Europe. There are differences. So if we could be able to, if the country which provides the cheapest treatment could actually receive more patients, perhaps in the other countries they would negotiate a lower price, and eventually joint procurement would be able to functioning in a proper way altogether in different, for different problems, for different drugs. I mentioned hepatitis C. I could mention the cholesterol, the drug which has been very much questioned recently against cholesterol and other type of drugs which will be developed in the future. So this is something that we need to keep in mind. I mean, the cost of innovation can jeopardize the full functioning of the health system as a whole if we are not able to address it properly at the European level.